Good afternoon, everyone. Ian asked me to speak about this really following the publication of the Freedom study, when it seemed quite clear that there seemed to be a higher stroke risk than was published in the Syntax study. And we had a little bit of a look of our own data to see if that was in concordance with what we had observed. So what Ian's asked me to speak about is a bit about the timing of stroke following coronary surgery, some of the late stroke rate in the trials, then I've just got some QE data just to show you as well, just to finish off with. So, of course, one of the problems we have when we're talking about strokes, of course, is there are different types of neurological injury. We have permanent strokes, which are obvious even to us cardiac surgeons. We have more transient episodes, TIAs, RINDs, which may or may not be diagnosed. And, of course, there's different rates of reporting from randomized trials and in the registry data that we see. Then we have sort of type 2 neurological injuries with delirium, coma, and sort of more subtle neurocognitive decline. As I said, there's different difficulties in interpreting the data. There's certainly different inclusion criteria, and to a certain extent, I think that probably does account for a lot of difference in stroke rates between different units. We've got different time frames when the strokes happened. If we think about in-hospital stroke rate, we look at things like the Syntax score. We know throughout Europe there's very different lengths of stay, so that's going to influence potentially what your in-hospital stroke rate is. We've got different diagnostic thresholds and obviously problems with data completeness. So if you look at sort of the literature, certainly over the past sort of 10, 15 years, there seems to be a consensus that the majority of in-hospital strokes occur in the immediate post-operative period. Sort of the most common figures around about 60%, with sort of literature between sort of 50 and 85%, and the remainder sort of 30% in the first 7 days, and a small proportion later on than that. So if we look at publication from Sinai, from Annie Amway's group with Dave Adams, he showed that in their sort of big look at stroke, they showed the incidence of stroke varied significantly by procedure, with an incidence of 1.7% in coronary artery surgery. And when they looked at the timing of these strokes, 80 patients, 60% were observed in the immediate post-operative period, which is probably the best data found on that. And then when we look at Bill Baumgartner's data, this is the only publication I could find that actually looked at prospectively timing the diagnosis of a stroke following surgery. And again, we can see 45% of patients were diagnosed on sort of day 0, with a small decline in numbers after that, so 20% on day 1, down to 10% on day 2, and then around about sort of 3, 4, 5% on the days after that. So what about the sort of contemporary trial stroke data? So it's slightly interesting, isn't it? I mean, when we look at Syntax, we have to remember that although there's a perioperative stroke rate of around about 2.2%, there was this slight funny sort of 0.8% stroke risk from randomization, but actually before the patients had surgery. But nevertheless, we have around about a 2% stroke rate at 30 days, which doesn't change in Syntax to 1 year, and then a small increase in stroke rate after that. And in red, I've just got the PCI stroke data. This is all data we're familiar with, so sort of a 0.4% stroke rate around the time of catheterization, and by 1 year, they have a stroke rate of about 0.6%, with a continuous ongoing small increase in stroke rates of 2.4% at 4 to 5 years. When we look at the registry, we should remember that the 30-day from procedure data, their stroke rate was only 1.2%. From 30 days to 1 year, it was an additional 0.8%. So again, around about 2 and a bit percent at 1 year. And by 5 years, the stroke rate was 3.8%. So when we look at the Freedom study, the 30-day stroke rate was about 1.8%. At 1 year, not a huge difference, so it was sort of 1.9%. But by 5 years, we have a stroke rate of almost 5.2% in these diabetic patients. So in summary, I'd say that the perioperative stroke rate is around about 1.5%. So we have about a 1% immediate postoperative stroke rate, a further 0.5% early stroke risk, and then by the end of the year, we've gone up by another 0.5% to around about 2%. And some of these issues suggested that was there a protective effect of dual antiplatelet therapy in patients going PCI, which could offer some of this, and is there an increased risk in stroke rates, particularly in late stroke when we compare these stroke rates to that in Syntax? So certainly there is some evidence that dual antiplatelet therapy will reduce your stroke rates. When we look at the active study, so this is a large study of 7,500 patients with AF who couldn't have warfarin, and they assigned them to receive either aspirin or dual antiplatelet therapy with clopidogrel. And what they demonstrated was in the dual antiplatelet therapy group, there's quite a significant decrease in stroke risk up to 4 years with these patients. But in the composite primary endpoint, it wasn't a huge difference, mainly because that was offset by an increased bleeding rate in patients with dual antiplatelet therapy. So that their final endpoint was that it reduced embolic stroke risk from 3.3% to 2.4%, so relative risk of 0.72 and highly significant, and a slight increase, as I said, in the hemorrhagic complications from 0.9 to 1.3%. But of course, there are new other agents out there at the moment. So this trial with dabigatran, in addition to aspirin, demonstrated a reduced hemorrhagic bleeding complication rate, suggestive that in these patients, such dual therapy may give you the protective effect against embolic events without the increased hemorrhagic complication rates. As I said, so part of this was our looking at some of the QE data, seeing how that compared to some of the late stroke results with Freedom. So we know that in diabetes they have an abnormal glycocalyx, they have systemic endothelial dysfunction, diabetic patients have an increased incidence of peripheral vascular disease, including carotid disease, they have an increased risk of chronic kidney disease and associated arterial stiffness, they have an increased incidence of cerebrovascular disease, and also an increase in atrial fibrillation, which we know is associated with a hypercoagulable state and increased platelet activation. So looking at sort of 10 years of coronary data at the QE, we had just over 5,000 patients on isolated coronaries, and just over 1,000 of those patients had diabetes. Just to note, we've had quite an aggressive carotid artery screening program since 2005, and we've got a fabulous local vascular surgeon who has excellent results doing pre-operative carotid endarterectomy under local anaesthetic that we're very privileged to have with. And certainly I think since 2007, we've also had a more sort of locally aggressive treatment of patients who have post-operative atrial fibrillation. So all the patients had proper coronary surgery on pump with either warm or cold blood cardioplegia. And we had a slight increase in number of bypass grafts from sort of a medium. So favourite number was 3 from 2000, 2007, and then 4 slightly later on, with sort of usual sort of cross-clamp and bypass times. So in the 3,500 patients with diabetes, 30 patients had a stroke, so 0.8%. 17 of them were permanent, so 0.3%. 24 of those 30 were over 75 years old, 4 of them had had previous strokes, and 11 of them had a Euroscore of over 10. So the stroke rate in your under 75, Euroscore less than 10 patient with no previous stroke and no diabetes was 0.12% over 10 years. But unfortunately, of the patients who do have strokes, 11 of those patients with strokes died in hospital. So it's clearly a major driver of mortality. What about patients with stroke? So 1,300 patients with either type 1 or type 2 diabetes, far higher stroke rates. So in hospital, stroke rates of almost 2%, 14 permanent strokes, 11 of these over 75, 7 with sort of other comorbidities, and 1 had had a previous stroke rate. And again, a high mortality associated with that. So then I wanted to look at the timing of these permanent strokes. So there were 55 permanent strokes between the diabetics and the non-diabetics. 31 of them were immediate post-operative strokes, and certainly looking at our notes, 4 were associated with re-exploration for bleeding, 9 with a low output state, some of them had a poor preoperative left ventricles, and 8 had had some sort of SIRS type response with high vasoconstrictors. Again, I'm not suggesting these are the reasons they had a stroke, but they were sort of temporally associated with that. Then we had 19 early post-op strokes, and the mean time to make a diagnosis, I'm not saying the stroke occurred on that day, but that's when then we made that diagnosis, was around 3 days. 11 of them had some sort of temporal relationship with development of new post-operative atrial fibrillation, and 7 of them were in patients who had some sort of multi-organ failure. And we had 5 late post-operative strokes with a median time to stroke of 14 days. All 5 of those had been diagnosed with post-operative atrial fibrillation, and I noted that 3 of them not been warfarinized. So the one-year stroke rate, Syntax 2.2%, Freedom 1.9%, and the QE at 1.5%. I'm not trying to suggest it's any better. I'm sure it's, as I said earlier, with the differences. But it's just interesting to note in the diabetics, we have a 2.1% one-year stroke rate, and then non-diabetics, 1.3% stroke risk. By 5 years in Syntax, we have a 3.7% stroke rate. In Freedom, we have a 5.2% stroke risk. And the QE at 5 years from sort of Dominic's data, we've got a stroke rate of 3.3%. But it's interesting that in the non-diabetics, it was 2.8%. In the diabetics, they had a 5-year stroke rate of 5.9%, which is what we see in Freedom. And then interestingly, if they had any sort of diagnosis of AF, either preoperatively or postoperatively, the 5-year stroke risk in these patients was actually 7.5%. So, I mean, it's a hell of a difference, isn't there, between a sort of 2.8% in non-diabetics to 7.5% in diabetic patients with atrial fibrillation. So in conclusion, I think in low-risk patients, the risk of a permanent stroke following coronary artery surgery is clearly very low. I think even in high-risk patients, the risk of stroke is low. 40% of patients' strokes occur post-operatively. Dual antiplatelet therapy reduces the incidence of embolic events in patients with AF, but is unfortunately associated with an increased hemorrhagic risk profile. Diabetes appears to be associated with an increased risk of perioperative and late strokes, and the mortality associated with post-operative stroke remains high. And I think that just to pull on implications, clearly clinical trials of either surgical techniques or against PCI need to take into account the different stroke risk profiles of such patients, and perhaps patients with diabetes and atrial fibrillation need a more aggressive approach to thromboembolism, anticoagulation, or atrial appendage type approaches. Thank you for your time.
Thank you very much.